everyone, and welcome to another Heart for PCOS interview as part of the 10th anniversary of Heart for PCOS, which connects PCOS with cardiometabolic health and reducing risks for cardiovascular disease. Today, we have a really special guest that I'm always so excited to sit down with, Dr. Tanya Wylde. Dr. Tanya is a best-selling author and Ontario naturopathic doctor with an emphasis on therapeutic lifestyle changes. Dr. Wylde has been able to work with thousands of people seeking optimal health. She is committed to health education and empowering patients with the most current information on health. Dr. Wylde's primary focus includes helping patients with weight loss, type 2 diabetes, hormone imbalance, and infertility, and conditions like PCOS. And Dr. Wylde is also a PCOS patient, so she can give us a lot of perspective on how to treat it and how to deal with it as a patient. So welcome, Dr. Wylde. Thank you for joining me today.
Thank you so much, Ashley. It's such a pleasure to be here.
So I want to just start off by talking a little bit about what you practice, which is naturopathic medicine. So for those who do not know, what is naturopathic medicine?
So naturopathic medicine is a form of medicine where we treat with herbal medicine, nutrition, and primarily we always look at lifestyle medicine as the base. So looking at a person's life and evaluating where we can help them find balance in their sleep, perhaps, or in their mental health, and finding space for better self-care, getting in a more balanced nutrition regime for them, and perhaps bringing in exercise. And if we find that they're kind of too flatlined and exhausted, depending on what condition they have, they're coming in feeling well, then we might be doing baby steps along those changes and uncovering deficiencies and treating hormone imbalances so that then they can then work on those lifestyle changes, because it's not as easy as just saying, I want you to get more sleep. What if you can't sleep? Or, exercise. I need you to start moving more. Well, if you're anemic, that's probably not going to really happen. So we basically try to uncover the root cause of why someone's feeling in a certain way, and then address their conditions. But we treat people, although we treat conditions, we treat people primarily. So it's a very holistic form of medicine.
I love that. And with naturopathic medicine, the one thing that I do love is it's a whole body approach. And as you said, looking at root causes. So what are some of the causes of PCOS that a naturopathic doctor might discuss or might look for?
That's a very good question, because I don't think that, we cause PCOS through our lifestyle. It's very important to distinguish that. From my understanding, PCOS is a genetic condition. So there may be certain environmental factors or lifestyle factors that could trigger those genes to get activated, perhaps when, in utero, or like when you're in your mom's womb. As an example, there's a higher chance if you're a daughter of a woman with PCOS to get triggered with excess androgens from mom, to then develop PCOS yourself as a girl or as a woman later on in life. And boys are more likely to get metabolic syndrome later. So that could be like an environmental factor. But as an example, I didn't get it from my mom. I'm pretty sure that I got it from my father, because as it turns out, he had type 2 diabetes, and probably somewhere in his lineage, someone, had that gene. Maybe he did. And my half sister, I discovered later when I met her at 16, had PCOS, and she really didn't get this diagnosed until her 50s, based on her own daughter now having PCOS and then looking at her history. So sometimes it takes, as you know, like 3 doctors to get a diagnosis. And sometimes you're in your 50s and you're finding out, looking back or seeing your own, family, sadly or unfortunately, have to kind of suffer for a while until they get a diagnosis and the right help.
No, absolutely. And I'm so glad that you brought up the point about it coming from your father's side, because a lot of times when PCOS patients are talking about, no one else in my family has PCOS, they have to realize that it doesn't have to be a direct connection to someone having PCOS, that there are other markers like people who have insulin resistance or diabetes or even cardiovascular disease that can predispose someone to having that perfect genetic storm to create PCOS, like you said, in the womb. And then eventually years later, we find out that we have it. So where do you start with patients who have PCOS as far as like family history or physical exams? How do you approach someone who comes in and says, I think I might have PCOS?
Right. So before I jump into that answer, I'm going to say what makes me super passionate about the cardiovascular component is that sadly my father passed away at 62 from a massive heart attack, and he had type 2 diabetes that was poorly managed. So definitely, I'm glad we had that conversation about the genetics. And even when a patient comes in and we're kind of starting out with them and they just don't feel right, perhaps, and they're not ovulating or menstruating, and perhaps their doctors haven't really given them, more than it's okay that you're not getting a period more than 4 times per year, or perhaps they've suggested going on the birth control pill to regulate them. You don't actually have to have a blood test to confirm that you have polycystic ovary syndrome. So I'll often say, okay, you either have to have a clinical or blood test showing that you have excess androgens. So androgens being testosterone or DHEA, on blood work, dihydrotestosterone. There's just so many types of testosterone. So that's why I don't rely on the blood tests. Usually there's some kind of clinical symptom. So perhaps somebody has acne or excess, hair growth on their chin. Like I plucked my chin before I came on today because I was like, not that you can see, but anyhow, because that's one hard thing to treat when you have PCOS. So the excess, either clinical or blood androgens, you're going to have that, or perhaps you have irregular cycles lasting from one cycle to the next more than 35 days apart or less than 21 days apart. So irregular cycles. And then a third finding would be, you don't have to have the third if you have the first two, would be a pelvic ultrasound showing multiple follicles. And the name polycystic ovary syndrome, it's not really totally reflective of what you're finding on a pelvic ultrasound. You're actually looking for lots of follicles. So polyfollicular ovary syndrome could be a rename, but we had that conversation, I remember before. So it's like those 3 criteria, and you don't really need all 3, you need 2 of 3. But what ends up often happening is that as you're going along, getting your diagnosis, you're always reaffirming, oh, look, the ultrasound shows it. And oh, look, one of the blood tests show it. We're really trying to help a patient understand what symptoms are connected to their PCOS once they go through the Rotterdam criteria and get that official diagnosis. And then we're looking to assess their lifestyle, make baby steps to change so that their PCOS isn't triggered by lifestyle, not caused by lifestyle.
Right. So with naturopathic medicine, is it always just all natural and lifestyle changes, or can treatments also include using medications when it's appropriate?
Yes, definitely. There are times I consider myself an integrative naturopathic doctor because I really do believe there is a time and place for medications. I will sometimes prescribe cyclical progesterone to help a patient who has irregular menstrual cycles with really heavy bleeding, causing iron deficiency that's making her super tired. And then it's really hard to make those lifestyle changes. So we got to look at the root cause of everything, right? So if she's anemic and she can't initiate change, then we got to address that. She might have insulin resistance, and certain supplements like myoinositol and berberine aren't really helping her, and she's super tired, so she can't make the lifestyle changes and let's say I'm having her do some kind of level of intermittent fasting and nutrition changes, but she's like, I'm so tired, I'm not ovulating, and her insulin resistance is, peaking. So then we'll say, okay, maybe if this isn't working, we'll use metformin for a time and then transition off of that, because definitely there are times where we need something other than lifestyle, whether it be supplementation or medications, to kind of trigger that feeling of being feeling better, or sleep disturbances, addressing that, because if you are not ovulating, you're not making estrogen and progesterone. And estrogen has an influence on the dopamine in your brain, which is your joy chemical. And, progesterone has an influence on GABA, which makes us feel calm and helps us sleep. So you're basically like a perimenopausal or postmenopausal woman for certain phases of your, menstruating life when you're not menstruating and you're a woman with PCOS. So you can feel like a woman in menopause or postmenopause with hot flushes and insomnia. And so for me to say, okay, I need you to make lifestyle changes, it's not always that easy. So sometimes we'll use a combination of conventional medications, supplementation at first, to help them.
I love your approach to that, and that you're open to utilizing tools and resources that will help the patient, no matter what that looks like. I think that's extremely important, which kind of leads me into my next question, because as someone who is not only a practitioner, but a patient, can you give us a little perspective as to why communication between patients and providers is so important in care with PCOS?
Yes, that is very big and key, because often we're educating our doctors. So it took me, I think, at least 4 doctors, or seeing 4 different doctors before I officially got a diagnosis, and I was in my early 30s. And Dr. Laura Shaheen, I remember interviewing her, and her saying that physicians, sadly, even gynecologists, she's a gynecologist, only get like 1 hour of schooling on PCOS. So the education has to be not just top down, but bottom up. So we educate based on us sharing our symptoms, and then making sure that if you're seeing an integrative practitioner, that you're sharing what you're doing with your conventional medical doctor, so that there's positive reinforcement. And if you're not getting a sense of support, then you may need to look for another doctor. Sometimes it takes shopping around, because at the end of the day, we need to meet a patient where they're at. And if your doctor's not doing that, if you're not being heard and you're only being dismissed and saying, you're hearing, which is a common, thing, and like our thread or meme or whatever in social media, like just go on the birth control pill and lose weight. Like, yeah, we all know what we need to do, but sometimes it's like it takes a lot to do those things, like lose weight, make lifestyle changes. And the birth control pill is certainly not the solution. It can definitely help in certain scenarios if somebody has severe acne, but it's a better alternative, in my opinion, than getting on Accutane and that kind of thing. But I think it's really important to communicate with your doctor and feel supported, and have doctors work together, like find your village, create your village. And it's when you feel supported, that's when you're willing to make change, because you're being motivated by the people around you, right?
Right. And so important, because again, from a patient perspective, how has having support and finding a network of others who are going through what you go through impacted your thought process, your practice, your life?
When I came across you guys at the time, like a PCOS challenge, and Sasha, at a time when I was kind of I've been a practitioner since 2005, and it was, at the time I would have been 26. So 5 years in, I had diagnosed other patients with PCOS. I knew there was something wrong with me. And, having been on the birth control pill for years, coming off of it, having cystic acne, I really felt lost, to be honest, because 8 years later, it took time to build my family. And in that time, I had you guys kind of educating me. I was learning from you, and I just felt really supported from a community perspective, being able to reach out and, you guys hearing me and things I had to offer, but then also me learning from you. And I think it's been integral in my growth and development. And in addition to that, having a fertility specialist who was like, you know what, Dr. Tanya, or she called me Dr. Tanya, I will do whatever will help you feel supported on your journey to conceive. If you want to do another Clomid cycle before doing IVF, you do what makes sense to you. So rather than, having your total choice stripped away and feeling like you're so out of control, like having a healthcare practitioner who empowers you, right? So and I had to change my fertility doctor to find that. So, and then even changing my family doctor dismissed the fact that my dihydrotestosterone was 3 times the amount that it should be, and didn't acknowledge it, didn't call. And I went in a year after and he said, "Oh, I didn't know what to do with this. So I just kind of filed it away." He could have called me. And so like, just, yeah. And then having a thyroid diagnosis missed. So, because the thing with polycystic ovary syndrome is, that there's a lot of other little conditions that can creep up. I had gallbladder attacks 1 year post delivering my daughter, and ended up in the emergency room for 2 weeks on and off. And I had a doctor ask if I was drug seeking because I was just throwing up and asking for pain medications. And it wasn't until I said, "Look, let's sit down. I have polycystic ovary syndrome. I have endometriosis. I have had ectopic pregnancies. I've had ovary torsion, cyst rupture, and I had natural births, and I did not take any pain medication, and I'm definitely not drug seeking. I've had lots of pain in my life and I need medications, and please send me to an internist." And so you have to advocate. So, and after advocating, they gave me an MRI and found inflammation of my gallbladder. So there's no visible stone, but I had inflammation of the gallbladder, which I'm certain has, there's a hormonal connection and genetic connection. And then a connection with PCOS. So my sister that I was mentioning earlier, who also has PCOS, and we're genetically connected to my father through my father, had gallbladder issues as well. So it's like realizing that there's so many different, phases of PCOS and components. And then so educating your doctor, but then also finding people who will help. Now I have an amazing doctor who just says, "You know what, Tanya, you get whatever tests you want to follow up on things." And I just feel so empowered. I get, and it's not easy in Ontario. I don't know how it is in the US, but, to have somebody who just says, "Let's do this." And like, we'll find things I wouldn't think of. It's fantastic.
No, it's very hard because the burden of care, pretty much worldwide and here in the US, has really been put on the patients. A lot of times you'll go in to see a doctor, and like you said earlier, they're saying, "Take this pill and come back to see me when you want to get pregnant, lose weight and everything will be fine." And it's so much more than that. It's so much more complex. And
It is.
I just think better care starts with better understanding. And that's why we're doing what we're doing. And I'm so grateful for your voice and being here today. So with PCOS, right, we are starting to recognize the profound impact it can have on metabolic health and increasing cardiovascular risks due to factors like high cholesterol and insulin resistance and non-alcoholic fatty liver disease. So how can we reduce risk factors in PCOS for patients for cardiovascular disease with naturopathic medicine?
Making sure that they're ovulating, I think, is a big key, because estrogen is protective for the heart. So if you're going for years with only 4 menstrual cycles per year, because that's acceptable, because your lining's not getting thick, and maybe you're having progesterone withdrawal cycles, that's not enough. Estrogen is protective. It helps to relax the arteries, and it helps to ramp up the good cholesterol, so HDL, and lower the LDL. And it also helps with insulin resistance. So the solution, again, is not withdrawal bleeds and Depo-Provera, progesterone withdrawal. It's getting the patient ovulating. That's key. And then managing insulin resistance that way as one, mode. And that could look like, while we're trying to work on getting a person to lose weight, we're supporting them with estrogen and progesterone, which then will cycle forward to improve insulin resistance, get them energized, and then having them make healthy lifestyle changes. So estrogen, ovulating, not just progesterone, although the whole package, and then teaching and educating, and then having different expectations from, what you would expect from showing up to a family doctor. Instead, kind of making sure you have a team, like a village, and naturopathic doctor, acupuncturist, like in your corner, helping you to ovulate and stay on top of your lifestyle. Because yeah, sure, we might know and we might not know what to do. And it helps to have people advocating for you and teaching you and keeping you on track. It's a nice little dopamine joy hit when you show up to your practitioner and you're like, I did it. I was sleeping really well, and I was monitoring my nutrition, and I'm feeling really good about balanced eating, and I'm developing a healthy relationship. And so you're not just like, eat less, move more. That's not the solution. It's like, it takes a lot, because we're also dealing with patients who, when you have PCOS, and you're trying to get ovulating, you might have joint pains and you might have physical limitations. You might have coexisting conditions like endometriosis, so that when your period does show up, you have to manage that because you got dysmenorrhea, you're flatlined. Like I personally had endometriosis, and or I guess I still have it. It's managed, but pre-children, I was mentioning, you're flatlined and throwing up and in pain. And so there's different kind of conditions that have together. So it's really, really important to work at the holistic perspective to prevent cardiovascular disease, because it's not just, take a blood pressure medication one day and take cholesterol lowering medications one day and address type 2 diabetes. It's preventing all that by supporting the reproductive hormones and the lifestyle. Does that make sense? I know I go on tangents.
No, it totally makes sense. And it kind of helps segue into my next question, because how important is it then that because I know with naturopathic medicine that lifestyle plays a key role, but just how important is that role in managing PCOS and preventing things like cardiovascular disease?
I think lifestyle and naturopathic medicine is very important. I think that, when I was 16, I knew I wanted to be a naturopathic doctor. And at the time, nobody knew what that was. I'm 45 now. And I'm so enthused by the changes over the years and the knowledge that we exist and that we do play a very important role. And I think a lot more family doctors are realizing that they're specialists in clinical screenings and, acute care medicine, and that we do play this integral role where we can guide patients in between visits so that they are less sick and, working on preventing chronic illness. I think it's, we definitely play a big role because we are regulated, and we know what we're doing, and we're supportive, and we can read and understand. We can diagnose. We can do lab tests to, better understand where a person sits. And we are known for testing more often than family doctors, because we're not just looking for, anemia, for example. We're looking for iron deficiency and optimizing, or vitamin D. Vitamin D is an example. A family doctor in Ontario, it used to be covered. They would run vitamin D. Now you have to pay for that test. So the patients will pay privately. And it's helpful because you get to see where you're at. Are you absorbing the vitamin D that you're taking? So they might say, oh, you're low, take it, done. We'll say you're low, take it, retest in 3 months. And, if your thyroid, if you have PCOS, we would want to be screening you for thyroid annually, or if some kind of symptoms came up. And we can do what's called a fasting insulin glucose challenge, not just the A1C to see how your blood work was over the last 3 months. Maybe your insulin's working so hard to regulate blood sugars, and you're wondering why you're feeling so tired after eating. But it's the insulin resistance that's creeping up. You don't see it unless you do these specialized tests that right. Maybe an endocrinologist might run, but maybe not even.
Yeah, crazy. Here's a final question for you. We know that 80% of cardiovascular disease is preventable through education and awareness. So I know we talked a little bit about you being a patient, and that you also have a deep connection to cardiovascular disease and what happened with your father. So why is it vital that we recognize PCOS as a serious health condition and all the associated risks that can come with it?
You definitely hit the nail on the head. If 80% of cardiovascular disease is preventable through education and awareness, and we're super high risk, we need to support patients with PCOS because we're at higher risk for inflammation and elevated CRP, which is a marker of an inflammation within the cardiovascular system, and that damages arteries. And then our body we try to plaque that up. So we have to, monitor our triglycerides, which tend to creep up with the insulin resistance, which also causes our body to try to, naturally band-aid that up. And we're at higher risk for heart attacks and stroke at an earlier age because of our insulin resistance and type 2 diabetes. 50% of women will develop type 2 diabetes or be at risk for type 2 diabetes by the age 40 when they have PCOS, right? That's the stat. And that itself will be a huge factor in, pushing cardiovascular disease later. And we lack hormones often, or we have irregular imbalanced hormones throughout our lives. If we can work towards balancing that and then supporting women post-menopause, because we had lack of hormones, right? And it's not just about the reproductive years. That's another thing that I really learned from you guys, because I thought, once I was diagnosed, I was like, oh, fine, I'll go through my fertility journey, I'll be great. But I didn't know that, later in life, I'd be at risk for Raynaud's syndrome and osteoarthritis and bone density issues. These are all things and consequences of having polycystic ovary syndrome. So we're at risk for quite a few things, all interconnected with the reproductive hormones. So, getting women ovulating through those years of reproduction, but then later, and supporting them if you're one of those 70% who struggles with fertility, and then later in life, helping a woman through the post-menopause journey and looking at maybe even, understanding hormone replacement therapy better, because we did lack, many of us, years of having estrogen. And then now I find that my patients who have PCOS who are in perimenopause, their perimenopause is much more intense. And then their postmenopause as well, the symptoms. So supporting women through that. And we know that estrogen, there's this big Women's Health Initiative study that was done back in 2002, and everybody was petrified after that study the results were released, and it was inaccurately represented, saying that, hormones cause breast cancer. As women with PCOS, we're at risk for breast cancer because of the lack of estrogen, not because we make extra estrogen. So, and then it turned out that the arm of women who were on estrogen had, less breast cancer and cardioprotection, as long as they're, we go on estrogen replacement closer to the time that we've had our last period. So in our, early 50s. If you wait until you're 60 and you're a woman with PCOS and you go on hormones, that can be dangerous because your arteries harden without estrogen. And then all of a sudden you go on estrogen, it softens, plaques, then you can get strokes and heart attacks. So it's like really educating doctors on the safety and, and treating everybody individually. And I think it's really important because we do have that higher risk for heart attacks and strokes. We've got to do everything from insulin resistance or insulin support and estrogen and progesterone support where it makes sense for any individual, in addition to all the lifestyle changes.
Absolutely. Absolutely. I couldn't agree with you more. And especially a lot of people don't realize that things like plaque deposits or atherosclerosis can start in patients with PCOS as young as in their 20s. So we have to be hypervigilant. We have to follow patients through the lifespan, and we have to recognize that it, like you said, it's beyond reproductive years. It's the only way we're going to fight back against these cardiometabolic risks and lowering the risk of cardiovascular disease. So Tanya, I would love you to share with everyone, how can people connect with you, find you on social media, websites, book an appointment with you, and learn more?
Yeah, sure. So if you're in Ontario, you can book an appointment with me. I'm at drtanyawylde.com, drtanyawylde.com. And I'm also on Instagram at drtanyawylde_NB, same spelling. I'm also on Facebook. And follow me. I will often give you little tips and motivation to stay on track and or kind of uncover, the root cause of what's going on with you.
I love it. I love it. I love it. And I always love sitting down and chatting with you and hearing your perspective. And I thank you so much for sharing your expertise, your insight, and your personal journey with PCOS with all of us today. And everyone, I thank all of you for joining in for this interview, and I encourage you to get involved, to raise your voices, and to follow along Heart for PCOS throughout the month of February. And Tanya, is there anything you'd like to leave all of us with? Any final thoughts or tips or comments?
I would say three things: advocate for yourself and surround yourself by uplifting positive women like you who also work on managing PCOS so you feel less alone. And finding balance is a lifelong journey. It doesn't end at one, practitioner or at one phase of your life. It's always in your life, and it's about progress, not perfection.
That is the best message of all. Thank you so much again for your time. Have a wonderful, wonderful day. And everyone, thank you for joining us for Heart for PCOS.